Hey, thank you, Susan. Dr. Peter Lepine is a professor emeritus at MSU, where he was tenured in the Department of Communicative Sciences and Disorders, with additional appointments in the College of Osteopathic Medicine, in the International Health Institute and International Studies, and programs in the Center for Latin American and Caribbean Studies. Dr. Lepine has a PhD in audiology and speech sciences, with an emphasis in geriatric medicine and phonosurgery. Dr. Lepine is a recipient of the Ralph Smuckler Award for Advancing International Studies and Programs for a 16-year history of extramural funding to provide clinical care to cleft lip and cleft palate children in the Yucatan in Mexico. Dr. Lepine also was an independent health care provider for over 3 decades at Mid-Michigan Ear, Nose, and Throat in the Lansing area. Peter enjoyed a fulfilling career that combined research, teaching, and clinical service, and as his former next-door neighbor of almost 30 years, I can attest that there are 3 places where Peter feels at home: on Butterfield Drive in East Lansing, where he lives, in the UP, where he grew up, and in the classroom. Peter is very eager to make his presentation today, and Peter, we're very eager to hear it. So welcome, Peter.
Thank you, Tom. I'm going to share my screen so everybody can see things. I can see a couple of you on the side here.
Looks great.
Thank you. I apologize for looking celestial. This is Michigan and the sun is out, and it unfortunately is shining in my office. So from the looks of the angle, I'll probably be out of the sunshine in a short time.
Dr. Lepine, I wanted to mention that because we had tested this earlier, just so you're aware, we actually are. I'm seeing the outline. So you were in presenter mode when we tested it earlier, and I just want to let you know. I'm sure that this is fine.
Yeah, I'll switch back.
Okay.
How's that look?
It's not being shared right now. So what I'm going to have you do is start from the beginning. My guess is you have your PowerPoint presentation up with just that one screen. So now go back to the share screen button on your Zoom controls.
And this one, right?
I actually can't. Yep. It is starting to share, and now perfect. That's what we did last time, or that is great.
Okay.
Great.
Susan is very helpful. This is the first time since 2013 when I wasn't the host. So I'm not used to being on this end of the process. Let me get started. My initial thanks to Tom. We miss having the Wolves as neighbors. I particularly miss hearing Mary play the piano. So when Tom asked if I would do this, I was very happy to get involved. I don't want you to be stressed out. I figure situations like HASP are supposed to be opportunities for people to learn a little bit more than what they've had. So this is our plan for the day, all right? You can tell I'm a high stress guy. So this is not going to be complicated. I might go through some things that you've never heard before, and that's fine because Susan's recorded this, so you have access to everything that I'm going to use. I'm very happy to answer questions. As Susan said, the end might be easier for everybody, but if one really grabs you, just text or chat it to Susan. I have 131 slides. That's okay, Tom. We'll be all right. I am actually using presenter view because sometimes I'm going to jump ahead by 10 or 12. So we're not going to do 131 slides. None of this will be on your exam, so you don't have to worry about that. This is the most important thing. All right. If I say anything controversial, blame Tom. Smile. Remember, I can see you. So this is supposed to be fun. And just remember that, all right? I've taught in both medical schools at MSU. I've given a talk similar to this on almost every continent. Sometimes it helps to get people's attention. So I've let this sit there long enough for those of you that are good readers, but I oftentimes, with medical students, first-year med students will use this question. And you and I already know it's misleading, okay? What's the most sensitive organ of the body? And of course, med students are a tad perverse. They usually think it's something else, but the reality is this is a trick question. The larynx is not an organ, but what it is a collection of cartilages and muscles and a bone that are extraordinarily sensitive to elements of our lives. It has a biological and a non-biological function. So just for the sake of consistency, although I know HASP viewers are highly educated and trained, we're going to talk about the larynx, not the larynx, but the larynx, okay? Yep, the bad stuff first. Excuse me. We're going to do a little anatomy and phys, and don't worry about it. We're going to hit the 9 cartilages and 1 bone and a couple of muscles, but that's only as to lay a base for the remainder of our chat. So I have a video of the set of structures that we're going to talk about. There's 2 portions to this video. The first part is at normal speed. The second part is under video stroboscopic conditions. You'll see some slow motion vocal fold movement. I don't want you to be grossed out. I just want you to look at the movements that you can see. So you're going to see opening and closing of the folds. You're going to see them move very rapidly. You're also going to see them get longer and shorter. And if you're watching carefully, you'll see that image come toward you and move away. I want you to recognize the dynamics of this particular anatomical structure, okay? Susan. All right, let's see if this.
I'm here. Are you trying to play the video? Sorry, I was just working on something.
No. I'm using a mouse, which sometimes skips. So I'm going to just use the keyboard instead of the mouse. But
okay.
Sorry. Here's the video.
Nice view. Good. E again.
They're moving very fast.
Other way. There. And E.
That's normal speed.
He. Pitch glide from your lowest to your highest.
They got longer, they got shorter.
Nice. She likes this thing.
Now slow motion.
He. No vibrato.
Okay, let's put this into context a little bit. What you've just seen is a collection of 5 small internal muscles, 1 bone, and 9 cartilages, some of them singular, some of them paired. But all of this is fundamental to how we communicate. So for the rest of the morning, we're going to talk about how we as humans create voice upon which that structure we communicate. Speech is voluntary, right? Speech happens because we choose to do so. All the things that we think, all the rules of grammar, morphology, and syntax, all that cool language stuff is brain-driven, cortical. But the decision to chat or talk is a voluntary act. So speech is a motor phenomena. Language is essentially a central nervous system phenomena. It's cognitive, but we're going to talk about one of the 5 speech processes. The 5 are respiration, phonation, articulation, and resonance. We could throw prosody in if we wanted. But for the morning, we're going to focus on the process known as phonation, which is creating the sound that we do for voice. And it's driven by our respiratory system. So I want you to think about how you talk. Typically, you do that spontaneously. You really don't think about it. You decide you're going to make a comment, and you can do that. There's some literature that suggests that we speak in segments of about 14 phonemes per second, 14 speech sounds. There's about 101 muscles for speech. If you take those phenomena for all of the little synaptic elements, the nerve firings that happen in those 100 muscles and 14 syllables per second, you and I are functioning at about 114,000 synaptic events per second just to talk. How cool is that? And you never give it a thought, do you? The other interesting phenomena about our voices and how we talk is this structure known as the larynx regulates the sound that we create. So let's take Tom as a perfect example. The name Tom has 3 sounds. A T, which is an interdental, it's voiceless. The the vowel in Tom is phonated, it's a vowel, right? The M sound is a nasal, it goes through the nose. What you have is a voiceless, voiced sequence. So the larynx has to open up and hold itself apart to get t, and then the vocal folds have to vibrate. Okay, Susan and I are very cool because we have Upper Peninsula ties. As a born and bred Youper who's used to talking in the cold, my rate of speech on a daily basis is about 165 words per minute. This morning, it might be a little faster, but just imagine what the larynx has to do in 165 words per minute to mitigate voiced versus voiceless sounds while we speak. And yet, you never think about how you do that. Peter, eat, eat, If I were to say my name rapidly, Peter, what you hear is everything is voiced. What's happening is that first bilabial plosive sound and the middle interdental, they're voiceless. So your larynx is always responding in a fairly sophisticated way. Let me hop a little bit. I think this is an important phenomenon. The larynx is just a sphincter. You've already got it. I don't even need to put this on the test. It either opens or it closes. That's it. It's binary. It either opens, like yours now when you're breathing, it's open. And if you choose to talk, you're going to take a breath in, pull those cords together, and the air beneath them will blow them apart, and they'll start to open and close. So it's just a binary phenomena, but it's a cool binary phenomena. It is the most sensitive organ of the body in a systematic way. So a guy from the UP says, what happens if you swallow a bug? You cough it out. That's the cough reflex that's driven by your true vocal folds. What happens if somebody sneaks up on you and scares you? And the first thing you do is, you take an immediate abrupt inhalation. And you may, from a vasovagal response, you may even phonate. Okay, that's a response. It's part of your fight or flight mechanism. It sets the chest. So when you close your vocal folds to do something requiring endurance, your body can fixate from the armpits down. Well, if you're lifting a heavy object, you have to have the larynx to close that airway off. Yes, I see there are 3 people with X and Y chromosomes, and the rest of the group has 2 X's. So for childbirth, right, you have to set the chest to expel a fetus in childbirth. The larynx is extraordinarily valuable. Tom knows, having talked over the fence many times, I started out part of my career working for the FBI and the CIA, and we used to measure stress in the vibrations, the subtle vibrations of people's voices. So the notion that the larynx is extraordinarily responsive to emotion and stress is pretty obvious. All right, here we go with the good stuff. And I'm not going to spend a lot of time on this, but I just want to use it to get to the sets of slides that have to do with functional voice disorders and eventually some head and neck cancer. So we're just going to get some basic goodies out of the way, all right? We use a boundary anatomically for the level of the vocal folds. The Greeks were cool. Anatomy doesn't change a great deal. It does change, but anyway, the Greeks like to label things. So the space between the vocal folds, the space between them is called the glottis. If your vocal folds are abducted or taken away from the midline, you have an open glottis. If your vocal folds are together, they're adducted, they're brought to the midline, you've eliminated the glottis. But everything is judged above and below the glottis. So all of you right now have an open glottis. You're all breathing, thank God, eh? But you're all breathing, so your glottis is abducted. The structure that we're going to talk about is primarily cartilaginous. There is a bone and there's a variety of muscles. Some muscles are inside the larynx, some muscles are outside the larynx. But we're going to talk about each of those structures. Now I'm going to hop ahead a little bit, just like I promised I would. Okay. One of the other elements I want you to recognize about the larynx is a protective mechanism, okay? It's a non-biological organ. It allows the transfer of oxygen and gas between the atmosphere and your pulmonary system. That's what it does. It helps us breathe. It is a biological organ. We have adapted it to become something that we can use on a daily basis. So physical need will always take precedence over personal need. For example, if I go run, dear God, if I go run 3 miles, I'm going to be out of breath. I'm not going to be able to talk after running 3 miles. That's my biological need to get to some homeostasis, right? Once I recover from that oxygen debt, then I can start to talk again. So the larynx is originally a biological mechanism to manipulate your airway, but it does have this other function that we as humans can use. Here we go. Bits and pieces, okay? Don't sweat it. They're all there. You can go back and read them in another time. The hyoid bone is the upper portion of the laryngeal mechanism. Technically, anatomically, it's the base of the tongue, but everybody includes it as part of the larynx. So the remainder of the larynx is suspended from the hyoid bone. If you take your thumb and index finger and put it right under the angle of your chin, you can feel your hyoid bone. Let's do this just for fun. So take your first and third finger and put them in that little gap between your hyoid bone, and I'll just tell you the thyroid cartilage. But put your index finger on your Adam's apple and push back. All right, you're shortening your vocal folds. So where your index finger is the level of the glottis, which is also the level of your vocal folds. So everything hangs from the hyoid bone. I love to tell college kids, watch people. You can see their larynx when they talk rise up and go down. The larynx will elevate and it'll fall. Higher pitches it goes up, lower pitches it drops down. Anatomically, you'll see it in a minute. There's a difference between male and female thyroid cartilages in terms of their angle, but most of the time you can watch the Adam's apple float. So the hyoid bone is essentially the base of the tongue, but the larynx and its structures are suspended from the hyoid bone. I think we might, I want to go back one. let's hit the thyroid. I talked a little bit about the Adam's apple. The thyroid is a singular cartilage. The hyoid is the only bone. The thyroid is a singular cartilage. It has kind of a shield shape. If you put your fingers on either side of your Adam's apple, I'm going to shake my larynx a little bit because you can hear it. There's quadrangular plates of cartilage that form this shield. What's nice about this shield, and you just manipulated it, is behind that shield are your vocal folds. Anatomically, here's the fact for you. The angle of the thyroid cartilage, left and right angles, are different in men and women. So the angle is about 120 degrees in females. It's about 90 degrees dispersion in males. That's one of the reasons why you can see an Adam's apple in a male, less so obvious in a female. And it's another one of the reasons why male vocal folds are slightly longer than female vocal folds. One of my favorite cartilages, which I hope will not confuse you, is the cricoid cartilage. From the looks of the pictures, we're all plus or minus 5 years, maybe one standard deviation or so. If I use this analogy with this group of people, it'll work. If I use it with college kids, they have no clue. The cricoid cartilage is signet shaped. So just like your class rings, right? It's broader in the back and narrower in the front. What's notable about the cricoid cartilage is it sits on the very top of your windpipe. It sits on the very top of the trachea. And it connects by virtue of these little feet, cornu. The cricoid cartilage connects to the thyroid cartilage. Big deal, all right? Don't sweat it. What I want you to know is that connection between the cricoid cartilage and the thyroid cartilage is a movable joint, okay? A movable joint. All joints in the larynx are diarthroidal. They all have synovial fluid in them, so they move nicely. Yep, when you think about our ages, we lose a little bit of synovia, right? Our joints get a little tighter. Some of these joints aren't quite as efficient as we wanted them to be. But first of all, this cricothyroid joint, if you look at the arrows here, lets the thyroid cartilage move. It'll rock forward, it'll rock backward. It'll rock forward, and tighten the vocal folds. It'll rock backward, and loosen the vocal folds. So that movement is a big deal. Okay, Tony Bennett. What's happened to Tony Bennett's vocal range over the years? He's still great, but he doesn't have the same range that he had. His cricothyroid joint and other diarthroidal joints just don't move as fast as they used to. And it's had an impact on his voice. Here's cool stuff, okay? There are two small cartilages. They're paired, one on the left, one on the right. They're called the arytenoids, all right? We like to call them pyramid-shaped. For our purposes this morning, they sit on top of the cricoid cartilage in the back. That's a synovial joint where they sit. So they actually rotate left and right. They rock front to back, and they'll even collapse medially. Your vocal folds, when we identify them shortly, attach to the arytenoid cartilages. So when you have that voiceless first sound in Peter, the vocal folds are abducted because of the rotation of the arytenoid cartilages on their base. Just for fun, I think we're going to hit the epiglottis in a minute. When you swallow milk, cheese, pasties, whatever the case may be, when you swallow, the epiglottis will fall back over your airway, the arytenoids will adduct and come together, and the tips of the arytenoids will actually fold over your airway, so you can't aspirate liquid or solid. That's a biological function. You finish the swallow, the arytenoids come apart again, the epiglottis raises up, and what do you do after you swallow? You take a breath in. So your airway has then been compensated. One more thing for fun. Each arytenoid has a little process. A process is just a projection. There's a process that points towards the front of the body, which is called the vocal process. There's a process that points towards the side of the body. It has the catchy name of the muscular process. Okay, vocal. The vocal process is the attachment to the vocal fold. The muscular process is the attachment to the muscle, to the muscles. So anatomy is pretty prescriptive in some way, but we're about to move into the connection of the vocal fold to the vocal process of the arytenoid. Now, I better explain a term. You've probably gone through life thinking of the term vocal cords. And I hope to show you in later slides, if we have time, show you in some later slides, the vocal mechanism is actually a shelf of muscles. It's not a cord, it's not a string. I used to ask my patients, where are your vocal folds? And they would tell me, well, they run this way in my neck, or they run that way in my neck. Okay, they're shelves of muscle, and they vibrate in a wave. You saw them move in the slow motion video stroboscopy. They vibrate in a wave. So we'll think in terms of how they move. I've got a summary slide coming up, so please don't be bothered by the speed with which we're going or the number of terms that we're using. In fact, I think I'm going to jump way ahead and just do that. Here's the epiglottis. We talked about that a little bit. The epiglottis is a cartilage. It looks from the front kind of like an oak leaf shape. If you look at it from the side, it's kind of S-shaped. It serves a protective mechanism. It has very little to do with voice or speech per se, but it is critical for swallowing. All right, I'm trying to get to my diagram. There it is. I'm going to sum up because I think I'm going into too much detail. This is what we've been talking about. If you take the entire laryngeal mechanism and section away the front half, if you just look at what we call a coronal section, we're looking at it depends on how you want to view it, the front or the back half. All right, so it's a cutaway, for lack of a better word. Here's your epiglottis. All right, there's the hyoid bone. Here's part of the thyroid cartilage. Here's the cricoid cartilage. You can't see the arytenoid cartilages in this image, but what you can see is the position of the true vocal fold, which in this case has two labels, the vocal ligament, which is the very edge of the cord, and the vocalis muscle. You guys are savvy. Vocalis muscle. I wonder what that connects to. The vocal process, vocal. So the vocalis is part of the vocal fold. What I want you to look at very carefully is this flat appearance of the vocal fold on its superior surface, okay? Look at how flat it is. And look at this cavity beneath it, the subglottal space. It actually makes air from the trachea converge right beneath the vocal folds. Mother Nature has fine-tuned those muscles to be focused directly upon discharged air. But look at the surface, right? It's flat. If you swallow something and it hits that flat surface, in other words, it gets past the epiglottis and hits that flat surface, that's a protective mechanism. You'll cough it back up. All right, where I'm headed is these two little appendages above the true folds. The cool word is ventricular. The less cool word is false folds, but you have two false vocal folds. So I always say, do this, all right? Your third finger is the true fold. Look how nice and flat they are. Your index fingers are your false folds. Look how far apart from the middle of the airway they are. When you swallow, the false folds collapse over the true and protect your airway. All right? The true folds, once again, look how close together they are above what is known as the conus elasticus, but it's above that little division of the airway. They're positioned to vibrate. They're positioned to make the sounds that we make for speech, as opposed to the ventricular folds, the false folds, which are further away from the midline. They're not designed for speech. In the first video, you could see two pink tabs just kind of moving in and out. They didn't touch, they just moved in and out. Those were the ventricular folds. Another contrast. The true folds, and I'm going to bring up a histogram here in a second, the true folds have muscle. See the red? The false folds don't have muscle. True folds can be made longer or shorter, tighter or thinner. False folds, no. So the moral to my rant is the true folds are for speech. The ventricular folds have nothing to do with speech. He swallows. Okay, he gets some fluid. This is what it sounds like when you use your ventricular folds. I can't change my voice. I can't make it any louder. I can't make it any softer. This is the best you're gonna get on a Wednesday morning. He takes a breath. These are my true folds. There's a pretty distinct difference in how those two structures vibrate, right? We all use our true folds. Once in a great, great while, I don't know, in 40 years of clinical practice, I might have done this 5 or 6 times. Once in a great, great while, in certain conditions, we'll teach people to use their false folds for speech, but ordinarily that's not a particularly common phenomenon. A little bit more on the vocal folds, and then I'm going to hop ahead to vocal health, okay? Each of those true vocal folds is composed of 5 layers, so they're not cords. This would be a right fold. If you're looking at it, you can see that it has that flat surface, but then along the edge, it gradually moves laterally or towards the side. But it's made up of different layers of density. There's a superficial, an intermediate, a deep layer. It gets thicker and thicker as you go. My point now, as we move forward, is I want you to think about the very surface of a true vocal fold. The epithelium is just the cover, all right? It's just a thin cover. But in this case, I want you to be aware of one type of epithelial cells, stratified squamous cells. We're coming back to that when we talk about head and neck cancer later, okay? There's literally 2 types of epithelium in the vocal tract, in the tracheobronchial tree, in fact. Something called ciliated columnar epithelium, and then the stratified squamous epithelium. Don't get hung up on it. For the fun of it, columnar ciliated epithelium is just a bunch of little tiny hairs, cilia, right? Just a bunch of little tiny hairs, and they're constantly beating upward, up, up, up. They're bringing mucus and debris out of your lungs. It's a little mucus blanket that travels on the ciliated columnar epithelium, and eventually you can, either swallow it or spit it out. Key point, the very edges of the true vocal folds, just the edges, are stratified squamous epithelium. Everything above the glottis and everything below the glottis is ciliated columnar epithelium. We're coming back to this. One of the reasons why the American Cancer Society has hoarseness as a warning for cancer, particularly laryngeal cancer, is that you can hear it. Hoarseness is audible, which means the stratified squamous epithelium on the edges of the cords has diffused. It's beginning to change shape. If you have a tumor or a mass that's above or below the glottis, that's ciliated columnar epithelium, you're not going to hear it. So we're going to come back to stratified squamous epithelium eventually. Okay. I'm skipping. Oh, I want to do one more thing. Sorry. Susan, don't yell at me. A A little bit about the vocal folds and how they're innervated, because this is I think an interesting phenomena. I popped up the right-sided branch, don't worry about it. I want to talk about the left-sided branch of the 10th cranial nerve, the vagus, which has a subdivision that we call the recurrent. No big deal, not an exam question. Think of the word recurrent, okay? The left branch of the recurrent laryngeal nerve drops down under the aorta of your heart from the brainstem under the aorta of your heart, and it comes back up to the level of the vocal folds, the left branch. The right drops from the brainstem under the clavicle and goes back up. They're different lengths, okay? The left is longer, the right is shorter. Time equals distance times time. When those nerves fire, one's got a longer distance to go than the other one. All right, a couple of interesting little ditties. The left is more exposed because it's longer. So when one has a paralyzed vocal cord, vocal fold, that might be due to a chest procedure, chest trauma, the likelihood of injury to the left vocal cord is higher because the left recurrent laryngeal nerve is more exposed to damage. So when a person has a singularly impaired vocal cord, it's probably going to be on the right if it's traumatic. You can have vocal folds that are paralyzed on both sides. That's less likely to be trauma, but more likely to be central nervous system phenomena. But what I wanted to mention is how we create voice, okay? In the 1800s, there was a theory called the neurochranaxic theory of phonation. Neurochranaxic, nerve timing. Everybody thought that for each nerve firing, the vocal folds would close or open. Each nerve firing, it was believed those nerves were symmetrical, so everything happened in the same order. I just told you the left is longer than the right. They can't be equal. They're not the same distance. To test the neurochranaxic theory years ago, probably before IRB, folks took a bellows, you know, that you might use for a fireplace to boost your fire, put a bellows under the trachea, pump the bellows to push air through the vocal tract. There's no nerves. It's an excised larynx. There's just a larynx and a bellows. Pump the air through them. The structure created voice. The neurochranaxic theory was proven to be false. Nerves don't fire that fast. There's a difference in the length. Thus, we create voice with a phenomena called the myoelastic aerodynamic theory. Muscles tighten, air blows the vocal folds apart. So I'm going to hop now to this one, which is probably vital. I've probably given you more anatomy than you wanted. Hi, Mary. She's behind you, Tom. But I thought maybe I'd plug this in as a little break. You know how the laryngeal mechanism works. Now let's talk about problems with voicing. All right. This is probably what you wanted to hear about today. Less so about anatomical structures, more about what is this voice stuff. So I'm going to start with things that are normal, okay? Vocal health. Health is certainly a relevant topic for all of us, but there are lots of things that contribute to our health. In my world, I'm talking about things that contribute to laryngeal function, which includes pulmonary function, right? But many things contribute to vocal health. So things like a person's individual personality, family dynamics. Okay, we all know families that are louder than other families. Medical histories. I will be somewhat candid and say, okay, I take a couple of medications that I know affect my fluid balance. Daily environmental differences to which we're exposed. I taught in London probably 25 times. And at the time, London was still using a lot of diesel fuel. And at the end of the day, if you'd blow your nose, there was a bunch of debris in your nose. Well, those are environmental influences. Occupational demands. If I do a 3-hour lecture, my voice is definitely tired. If I see patients all day, my voice is definitely tired. If I have a quiet job, like maybe a librarian, I probably don't have the same occupational demands on my laryngeal mechanism. We also have expectations about the quality of our voices. So sometimes that will change how we use them. When we lived in upstate New York, my wife worked for the Corning Glass Works, and there was a young guy fresh out of Cornell. He had an MBA and he was like 21 years old. It was absurd. He flew on the corporate jet, he bought art, but he was 21 years old. And all of the senior VPs were older than him. So in order to sound more administratively competent, he talked like this. He lowered his pitch on purpose. His expectations for the quality of his voice was he was a stronger advocate if he had a lower pitch. Mother Nature fixed that. That throws off all the balance in the larynx, affects all the intrinsic laryngeal muscles. And we're going to get there pretty quick. That for him was phonotrauma. That for him created small callus-like growths on his vocal folds that we call vocal nodules. He changed the balance of his mechanism. So we have expectations for how we should be sounding. All right, I mentioned phonotrauma. Basically, phonotrauma are behaviors that contribute to laryngeal injury. Could be a bazillion things. My daughter had colic. I'll bet you a dozen pasties that at a certain point in her life, she had vocal nodules, maybe screamer's nodules, but she cried all the time. Okay, that's legitimate laryngeal injury brought on by colic. 64% of cheerleaders have vocal nodules. Cheerleaders practice after school, they relate to other people, they perform in games. That's phonotrauma. Tom will smile. Tom Izzo, MSU's basketball coach, is a Youper like the rest of us. If you've heard Izzo's voice before a game and Izzo's voice after the game, you can recognize the impact of phonotrauma in that particular environment, okay? Let's think a little bit about things related to vocal health. There are some things you don't have any control over. Oftentimes, professional voice users, in particular vocalists, females have written into their contract that they do not perform when they menstruate. It's pretty straightforward. There's a lot of retention of fluid. The vocal folds swell, right? They can't vibrate in that modal pitch that a performer might like. There's not a whole lot you can do about that menstrual phenomena, but it does affect the quality of voice. That's an internal phenomena, I suppose. Some of the external things, I mentioned I taught in London for a lot. It seems no one in the world smokes as much as Europeans. There was a period of time when everybody in London smoked. Well, you're exposed to all that secondary smoke. That's an extrinsic phenomena. Even if someone does not smoke, you're still exposed to that secondary phenomena. So those are extrinsic things. Part of this, to address vocal health, is you have to evaluate the person's voice use. So you collect a case history, and it's a time to chat with the patient or the person and determine ways of how their life changes. Probably the standing joke is if you see a married couple who's been married for a while, and sometimes people who have hearing impairments talk louder, particularly patients with nerve losses. So when they're talking like this, right, that's going to cause some voice problems. Her voice is going to break down. The other member of the family goes, yeah, it's because she can't hear. Well, then you have this awkward spot as a clinician. You have one patient who's hearing impaired and another patient who knows somebody's hearing impaired, but then there's the debate. It's your hearing. No, it's your hearing. No, it's your hearing. No, it's your hearing. You need a hearing test to hear me. You need a hearing test to talk. It gets to be a little complex, but it has to do with case history. Why do people do what they do? Lots of good examples. We're going to see polyps in a minute. I had a patient years ago who drove a truck. He delivered salt to people's water softeners. He was alone all day, never talked. So he didn't have any hyperfunctional or phonotraumatic voice use. But whenever he dumped the salt into the water softener and all that, the fumes from the salt came up, it set him into a coughing fit. And he would cough for 15 or 20 minutes. He wasn't talking, he was coughing, and his cords were pounding. That's a non-speech phenomena, but that pounding, delivering salt all day long, day in, day out, left him with a couple of benign lesions on his voice box. So you do get a history from people. Teachers, I don't know that I could teach in the public school system, but the environment is such that there are kids, there are behaviors, there are tile floors, there are concrete walls, there are glass windows, voice rebounds all over the place. Teachers use their voice all day long to control their classroom. In the past, I would get lots of vocal nodule patients in the spring when the sun came out. Is it tied to the weather? Not necessarily. Is it tied to the kids being livelier because the weather is better? Yeah, that's probably more of it. So at that time, teachers had to use their voices in unproductive ways. So taking a good, clear case history is very helpful. Recovery is an individual thing. It almost doesn't matter what phenomena you're involved in. If someone takes your advice, they're probably going to be helped. If someone rejects your advice, they're probably not going to be helped. I guess I'm telling stories out of school. I used to laugh when patients would say, well, I'm not going to pay because whatever he told me to do, I don't have a problem anymore. I don't have a problem. I shouldn't have to pay for it. Well, okay, how'd you get rid of the problem if you didn't listen to what I told you? But compliance is a big deal, all right? It takes everybody different times to heal. It depends often on what medications are involved. It depends a lot on the person's mental status, how they use their voices, what are the demands. Recovery is a complicated issue. So there are many parts of recovery that can't be controlled. So sometimes you can't say, you know what, I'm absolutely sure you're going to get better. You're often in a position of saying, if you do these 2 or 3 things, I anticipate you'll be just fine. But you can't ever say you're great. Here we go. All right. Voices and non-prescriptive drug use. If possible, patients should never take non-prescribed drugs. And that's true for everybody, right? But some of the problems with non-prescriptive drug use, particularly marijuana and alcohol, which are defined as drugs, they affect one's ability to think, which certainly can mitigate and change one's mood and reaction. They change the way people act. Such things as tobacco could put a smell on breath or clothes, which make people respond differently. And various degrees of intoxication make people make poor auditory judgments. So let's hit alcohol, okay? Even a little bit, okay? Even a little bit of alcohol is going to decrease one's awareness. I live in a major college town. On any given football Saturday, I get an abundant exposure to a decrease in awareness due to alcohol use. Well, that lack of awareness undermines how we behave, okay? It undermines the same discipline that one might have ordinarily, or the same vocal technique that one might have when they're not impacted by alcohol use. So ideally, especially for professional voice users, avoid alcohol. Here's a biggie. I'll just say it right now. When we get to head and neck cancer, 94% of total laryngectomies are in patients who smoke cigarettes. All right, there's the first one. The next one, cigarette smoke is toxic, and it does contain a contaminant. It's got nicotine, which is an addictive phenomenon. Remember the ciliated columnar epithelium? All right, cigarette smoke is toxic. to the ciliated columnar epithelium. You lose that little beading blanket of mucus that's supposed to help get debris out of your lungs. Where does debris go? It runs downhill. So it collects in the base of the lungs and it can't get out. There's no more ciliated columnar epithelium. All right, I'll say it. If you've been around people who smoke, they cough, they hack, they choke. Why is that? They don't have any ciliated columnar epithelium left to clear their lungs. Other things related to smoking, cigarettes in particular, we're going to come to marijuana in a minute. Cigarette smoking has a significant impact on the lungs. And what it does is it creates the possibility of things like upper respiratory infections, episodes of bronchitis, potential for pneumonia, and of course, all those chronic lung phenomena like COPD and various forms of emphysema. It's just a bad thing, and we all know that. I think the thing that's stunning in terms of cigarette smoke per se is it's filled with tar and chemicals that are literally cancer-causing chemicals. So exposure to cigarette smoke is a very dangerous thing. Let me hop to marijuana. I'll do this one first. For those of us who do not smoke, we're exposed at some time to secondhand smoke. All right, read the bullet. The damage from secondary smoke carries about 40% of the effect of smoking itself. So secondhand smoke, for those of us who do not smoke, is a problem. It's a risk. I don't want that one. I'm going to change to marijuana. Okie dokie. Note the two red asterisks at the top. The data in this slide came from before marijuana was legalized in Michigan. So my guess would be these numbers are low, but it still exists. Marijuana is a fairly commonly abused substance in the US, depending on the country as a whole. So these are not Michigan data. They're national data. They're NIH data. 3.3% of young adults 19 to 28 use it on a daily basis. 54% of all people between 25 and 34 have used it at least once. What's the big deal? Marijuana burns hotter than cigarette smoke. THC, tetrahydrocannabinol, is hotter than cigarette smoke. How do you get it to your lungs? Straight between the vocal folds. So that added heat, right, has to pass across the vocal folds in order to get into the lungs. So that dries out the vocal folds, takes away that thin mucosa on the edge, makes them more exposed to damage, increases changes in attitude and displays of behavior and lack of discipline. So that can create a voice problem. I talked about cigarette smoking. I'm going to hop ahead. I threw chewing tobacco in. Less common here than it is in other parts of the country, but it does predispose folks to oral cancers, particularly in dentition, but it's also going to affect the level above the voice box. Here's the one I wanted to get to. Welcome to Michigan. Throat clearing and coughing. We live in an environment, especially those of you who live in Holland. You live right next to the Great Lakes. There's moisture rolling by you all the time. I used to see MSU students who came from west of Lake Michigan, Chicago, Iowa, Nebraska. And when they got here to East Lansing, they weren't used to the amount of moisture in the air, and they'd end up coughing and clearing their throats all the time. Kids with allergies, patients with asthma. What's the big deal? Coughing and throat clearing is phonotraumatic. They hit hard. And that pressure against the vocal folds can change the tissue structure and lead to benign lesions of the cords. All right, here's a bit about caffeine. Caffeine is fine, depending on how you use it, but it is a diuretic. What does it do? Takes fluid out of the body. Could lead to dehydration if you drink a lot of it. But if it's taking fluid out of the body, it's also taking fluid out of the vocal folds, which predisposes them to damage. I'm going to do this slide, and then because I looked at my watch, Tom, I'm going to switch to the head and neck stuff shortly. Dehydration, you can adjust it. Some of my patients would say, you know, I can't get through the morning without a can of Coke. I have to have 3 cups of coffee before I start my car. So you have to find ways to compromise. So I've always adapted the strategy, you know, if you have 1 cup of coffee, have 1 cup of water. You just get some balance. If you have 1 cup of coffee, have a cup that's half coffee, half decaf. But be aware of the diuretic effect and the drying effect of caffeine. Tom will smile. My brother-in-law lives on Mountain Dew. I don't know that he's ever had milk, but he's always got Mountain Dew. Well, it's full of caffeine, which of course will cause a whole bunch of things. Okay, I'm hopping ahead. I know Tom wants me to be on time. This is what I want you to see. Couple of slides. The causes of voice disorders. I've been talking mostly about those that are functionally based. They have no organic cause. They have no physical cause. There are those that are organic in nature. A paralyzed vocal cord. I just mentioned that a little earlier. There are some that are neurologic, like Parkinson's or multiple sclerosis will have a neurologic basis. Oh, I didn't want that. I hate this computer. I want this. All right, here's an example of a neurogenic voice disorder. You've probably seen this individual. He has a condition called spasmodic dysphonia, which is an uncontrolled spasm of the larynx. So now that you know about abduction and adduction, listen to his voice. And what's happening is his vocal folds are spasming shut. He's going to talk like that because his vocal folds are spasming at a time when they're not supposed to. So I'm going to start this and then move maybe 15 seconds into it or 45 seconds in.
The Kennedy family has been at the center of
Well, he's elated.
Yeah,
he was, you know, the Supreme Court decision, people should understand this, was effectively an exoneration of Michael because the court overturned it because it was a credible witness. There's actually 5 eyewitnesses that put him 11 miles away.
Okay. I have approximately 10 minutes left. I want to do some alaryngeal speech things. So let me just say in this case, and we can talk about it in the question and answer period, this is a voice phenomena that can be solved. It can't be cured. It is a neurologic change. There's a lack of a neurotransmitter that doesn't get produced in the basal ganglia. The neurotransmitter feeds the larynx. Nowhere else in the body will you find a spasm, but it's only in the larynx. So it's a focal dystonia. But botulinum toxin, medical grade, if you inject it into those vocal folds, that voice will clear up. Like all Botox, there would have to be subsequent injections, but I just wanted you to listen to that voice. All right, Tom, I'm skipping a bunch. Everybody, there are slides here for nodules and polyps and Reinke's edema, which would have covered that layer of mucus. And here is where I want to be. Okay, what happens when you don't have a larynx? Now, you have access to all these slides. There are slides about nodules, polyps, cord injuries, etc. You can go back and look at them. I've hopped ahead to make sure I'm okay for time. But what happens when the larynx is removed? Okay, the 9 cartilages, the bone, all the muscles, the top 3 rings of the trachea. What happens when the larynx is removed? You have no mechanism to create voice. I'm going to talk without a larynx, and you can do the same thing. This is what speech sounds like when you don't have a larynx. I'm laughing. You can make all the speech movements. You can follow all the grammatical rules of language. There is no power source. Speech still exists. There's just no carrier. You don't have vocal folds to vibrate. So I'm going to cover a few things, and I'll make it in 70 minutes, Tom. But I want to cover a few things about how do you rehabilitate folks who have lost their larynx. Here's a good example for a starter.
Sometimes you just lose a lung. Oh, you don't always die from tobacco. Sometimes they just snip out your tongue. And you won't sing worth a heck with a big hole in your neck.
'Cause you don't always die from tobacco.
'Cause you don't always die.
Okay, point made. You understand the ramifications of cigarette smoke. In this case, we're going to talk about laryngeal cancer. I can safely say, having lost a spouse to that horrid disease, we all have exposure to some form of cancer. It's just too common in our world. But today I'm talking about just cancer of the larynx, right? Not pancreatic, not lung, not prostate, none of that other stuff, just cancer of the larynx. For all intents and purposes, it's probably oversimplified clearly, but cancer is just when cells go nuts and multiply too fast. They're unhealthy cells. They grow at an outrageous rate, and it depends on what portion of the body they're in and what type of cell they are, but cancer is just an uncontrollable growth of cells. Now, the primary risk factors for head and neck cancer, they all have something in common. Inhaled cigarette smoke, marijuana smoke, pipe and cigar smoke, chewing tobacco. They're all based in one phenomena, right? The risk levels depend on how much of those four elements does one participate in, what type do they use, what toxicity level is there, and what kind of tobacco use there is. But the good news, laryngeal cancer is a survivable cancer. It can be treated, it can be managed. Yes, there are folks who do not live as a result of their cancer of the larynx, but there are always those case history elements. Sometimes people don't identify their symptomatology early enough, and the disease has spread or metastasized, and they have life-threatening problems. I get back to the comment earlier. One of the 7 warning signs of cancer by the American Cancer Society is hoarseness. Don't overlook hoarseness. We've all had head colds. We've all been hoarse. The rule of thumb, hoarseness for greater than 2 weeks, have it examined by a physician. Maybe nothing. If there are mitigating circumstances like a longstanding history of cigarette use, it may be something. So just use caution. Hoarseness can be part of an acute upper respiratory infection, and it too will pass, or hoarseness could be the sign of a significant health problem. I'm going to skip the slide that has to do with multidisciplinary teams. You can get to it. This is what I wanted to show you. The head and neck cancer types. Look at the top one. Squamous cell cancer. Where are those stratified squamous cell epithelia? On the edge of the cords. You can hear it. Other forms of head and neck cancer do not have the same impact. They're not audible. They happen in ways that you can't feel or here. So sarcomas, adenosarcomas, lymphomas, melanomas, all that stuff are inaudible. So remember that notion of the squamous cell epithelium. One more slide about that. All right. 90% of head and neck cancers are squamous cell epithelia. And they either localize or they don't. Okay, they're either keratinizing or non-keratinizing, but they do have variant types, which means there has to be some sort of biopsy to confirm it. But the point is, they're audible. I'll throw this one in for our age group. Clearly, one of the problems with head and neck cancer is cigarette use. Human papillomavirus is now mitigating to the larynx, and there is exposure to laryngeal cancer brought on by HPV. I think everybody knows this because we have so much exposure to the disease. Oh, can't talk, Tom. To the disease. All cancers are staged. Doesn't matter if it's prostate, cortical. Each category of cancer is broken down by the American Joint Committee on Cancer in terms of the tumor, the node, and the metastasis. So the tumor is the primary site. The node estimate has that cell type moved to the lymphatic system and moved to regional metastasis. And metastasis is, of course, how far away has it gotten? Did it spread? So we won't chat about T1, T2 types of exposures for removing the larynx. Let's just operate on the notion that the larynx itself has been removed. I'm going to do 3 or 4 more slides, Tom, and then I'll stop, okay? All right. Think about total laryngectomy, the removal of the entire larynx, taken out of the anterior of the neck. It is literally laryngeal amputation. So all the 9 cartilages and bones are removed from the neck. The trachea is cut on a little angle on a bevel at the 3rd tracheal ring. The trachea is bent up and attached to the neck. So there is something called a tracheostoma. Next slide will show you the impact of the tracheostoma. Okay, the hyoid bone is removed. The base of the tongue is anchored to the lower pharynx. The thyroid and the cricoid cartilages are gone, as are all the pharyngeal muscles and a part of the trachea. The moral to the story is this person now does not have a larynx. They can't create sound for speech. And it looks like this. All right, this is what you and I have if none of us have had a total laryngectomy. Air comes up through the pulmonary system from the lungs into the trachea. It makes those vocal folds vibrate, the aerodynamic myoelastic theory. Sound, as you saw in the first video, comes up through the throat, the pharynx, and it's manipulated by the lips, tongue, and teeth as it comes out in the form of speech. Okay, look what happens when the larynx is gone. A, there's no connection between the nose, right, the mouth, and the airway. Oh, I don't like that. I'm using a mouse, sorry. There's no connection anymore, which means air to and from the lungs goes right into the trachea. Welcome to Crystal Falls or Houghton or Hancock or Orlando. You've got ice cold air going straight into the lungs. There's no way to filter it and heat it anymore because the nose is gone. There's no way to humidify it because the nose is gone. How do you take a shower? You can't close that. That is your airway. How do you get soup off of a spoon? If you slurp, right, you create a vacuum in your mouth, in your oral cavity. You can't do that anymore. There's no vocal fold to vibrate and create speech. So that tracheostoma becomes a part of life. Fun question. If we were taking an exam, I'd put it on the exam. Mouth-to-mouth resuscitation. How does this person get mouth-to-mouth resuscitation? Can't go through the nose, can't go through the mouth. Yep, they're neck breathers. So it has to be it has to be resuscitation through the trachea, not through the mouth. Okay, I'm flying now, Tom. This is Jim Lauder. He's going to show you an electromechanical form of speech. This is a laryngeal speech, no voice box. So in this case, Jim is going to put an electronic device against the tissue, just the tissue of the body. That vibrator will transmit sound into the body, and here's what you will hear.
Hi, this is Jim Lauder of Lauder Enterprises. I'm here to introduce a variety of instruments that Lauder Enterprises sells and services. The first one being the Servox Digital XL.
Hello, how are you? 1, 2, 3, 4, 5.
It's a dual tone machine, very durable, runs on rechargeable store-bought batteries, AAA batteries. The next is the Servox Digital, been around since 2002. Very good machine, very similar, but this one uses a Servox custom battery. It's one that you cannot buy in stores, you have to buy online or mail order, but it is very long lasting. It's been a staple of the industry for years and years. Very highly recommended.
Hello, how are you? Servox Digital.
All right, you get the point. The source of sound is attached to the surface of the body, and it will carry that sound through the oral cavity. I've worked with Jim for a million years. I call him the crazy cowboy. He is a delightful man. His father, Edmund, was a laryngectomy. Jim created this company on behalf of his dad. But my point is, Jim will rebuild an electrolarynx for free for patients who can't afford it. So it's a nice group. The other form that you've probably heard when you were in school as a kid are people who use esophageal speech. Basically, that's trapping the bolus of air in the esophagus, then quickly returning it back. If you went to summer camp as a kid, there was probably some kid in your summer camp who could do the ABCs by burping. Burping is not esophageal speech. You have to trap that air bolus in the esophagus and get it back in order to form it into speech. So this is an example of esophageal speech.
Hi, I'm Dave Aitchison. I had my laryngectomy surgery April 12th, 2012.
A little bit more. You can see that this man is not using his hands. He has what's called a humidity moisture exchanger on, which there's content here for you on that. But he's taking in air, he's capturing it. He's using what's known as an inhalation method, but he's capturing it really quickly and forcing it back out equally fast. And what you hear, right, are not vocal folds vibrating, they're gone. What you hear is his tissue in his esophagus, the most vibrant point of the esophagus. I hate that. The most vibrant point in the esophagus, which will create that esophageal sound. Okay, last one, the gold standard of the day. Everybody wants tracheoesophageal puncture. Tracheoesophageal puncture, I've done thousands of them. A little silicone prosthesis that's placed between the trachea and the esophagus. So it's a small silicone device that sits on the front, I better describe it differently, on the back of the trachea and on the front of the esophagus. So when one breathes out, the air will be channeled through that little prosthesis and into the esophagus, where once again, the esophagus vibrates. So here's a sample of that speech sound.
Hello, my name is Toren, and I have a voice.
These are the devices. They're different manufacturers, they're different styles. Of course, they're different prices. I probably sped through that too fast. Here's Tom's favorite part. I went way too fast. I had far too much material. Clearly, I've left you in a position where you have to have questions, but let me do this first. All right,
Just-
Mr. Well, please tell Stephen that was for him.
Okay.
A
Well,
shameless plug.
yeah.
I feel badly. I went so fast. I left out a lot of content, but you do have it and you can go back through it and read it. Susan has my email address. If I said anything that was not clear, please email me. I'm not saying I'll respond, but you can email.
Well,
Please.
we're not letting you go so quickly because we do have some questions in the
Oh,
chat.
okay. Okay. I just didn't
No,
want to
you-
overlook that.
No, you, and I'm kidding. But we have probably 6 questions currently in the chat, and then we'll open it up. So you may have answered some of these during your presentation. We can just pass if so. Why is the resonance in your voice affected by acid reflux?
Ooh, that's a good one. I would argue resonance is not affected. I would argue vocal quality is, but depending on if it's laryngeal, pharyngeal reflux or gastroesophageal reflux, the moral to the story is somehow acid or bile, when you lie down, right, is getting to your vocal folds. And there is a picture of reflux in some of these slides, but essentially bile is an acid, right? So the acid settles on your vocal folds, particularly the vocal processes in the back of the larynx and parts of the true folds. If you look at the vocal folds endoscopically, they're hyperemic and reddened. If you magnify them, the edges of the cords are very bumpy. So it lets little pockets of air. So voice becomes rough and it sounds funny because of the bile that's collected on the folds. So resonance is the sound of your body the sound of your voice that's shaped by resonating cavities. So the throat, the mouth, pharynx, the soft palate, and the nose. A cool thing about resonance is that's your identity. Each one of us, it's like a fingerprint. But I could call Tom up and say, hi. The H is a glottal, it has no sound. The I is a diphthong, I. I could go, hi. Based on that little bit of resonance, Tom knows my daughter, Tom knows my address, he knows my birthday, he knows what I look like, he knows I'm overweight, he knows I'm a Spartan fan, just from that one sound. So the resonance of voice is your personal characteristic. I think the notion of reflux literally applies to vocal quality, which can be hoarse or strident or glottal fry, a lot of glottal fry.
Thank you.
Sure.
Why, Jane asks, why are the cells in the base of the tongue more susceptible to squamous cell carcinoma?
Cells in the base of the tongue are not susceptible to squamous cells. Cells in the vocal folds on the top surface, the edge of the vocal folds and the shelf of the vocal folds are subjected to or likely to be affected as squamous cell carcinomas, but things above and below don't have the same epithelium.
Okay. Thank you. Are there medications that can damage the larynx or larynx?
Suzanne?
Yeah, I heard you correct it. Will you repeat how it is actually pronounced?
Larynx. If you're in the UP, it rhymes with ice rink, so larynx. Sure, there are lots of meds that affect the vocal folds. Obviously, you should look up every medication that you take. But lisinopril, for example, is a common blood pressure med. It has with it a commonly recurring problem, which is it makes people cough. So folks have throat clearing problems and they cough and their pitch will drop, and that'll have some impact. Inhalers for asthmatics, some of the antihistamines that are used for allergy patients dry them out too much. But sure, there are a variety of meds that have an adverse impact on the larynx. Psychotropic meds that affect motor control, right? Maybe you might have some tremors in your hands or something. Well, those motor effects also affect motor function of the larynx. So there are a host of meds that impact the larynx. There is the National Center for Voice and Swallowing out of Denver produces a very good database of medications that it identifies their impact of those medications on speech and motor control for voice. Which if anybody wants it, just send me an email, I'll send you the link.
Thank you. Can you please address voice changes with age? I used to be first a soprano, now I'm an alto, and sometimes a tenor. Is there help for this?
The best help is a good singing coach or a good vocal teacher. Your body's changing. I used to tell my patients, like singers, your hands and feet are as old as your larynx. You know, your knee joints change just like the joints in your larynx change. There are physiological problems that happen as we grow older. There's a couple of slides about ossification of hyoid cartilage in the slideshow. Most of it is finding your proper optimum range for singing and staying within that. What I'm trying to say is your voice is going to change with age, but you shouldn't stop singing. If you get joy from it, you have to modify your technique so that you can continue to do what you really like. Vocal hygiene is critical, okay? No smoking, no yelling, no shouting, making sure you're hydrated, watch your medications, sing within your range. If you're in a choir, don't compete with the tenor next to you if you're an alto or a bass or a mezzo soprano, but stay in your range. But, under these chatty circumstances, the time limits that I have, I'd find a good vocal coach and keep singing.
Thank you. Can smoking marijuana or being exposed to secondhand smoke still have a negative health impact years later? And if so, how likely?
The probabilities decrease with time away from smoking anything of any sort. There is some data actually for cigarette use that implies, 15 years after you stop smoking, your lungs are essentially back to where they were before you started. Marijuana use will affect the larynx depending on how much use it has. It's possible, albeit less likely, but it's possible to end up with a chronic laryngitis or a chronic voice disorder if one uses it a lot for a long time.
Okay, this is a great question. Is vaping less damaging than cigarette smoking?
True answer? We don't know.
Mm-hmm.
Too soon. On the surface, it would appear to be, this is anecdotal, by the way, it would appear to be as adversely effective on hydration and fluids as cigarette use. I don't think what we know for sure yet, given the variety of vaping substances, is what are the chemical constituents of vaping cells and vaping pods to know what the long-term risk is.
Thank you. In the last question that I have, we have about 6 minutes left. If somebody wants to think about a question, they might open up their mute button for. The last question is, do you know what percentage of Americans have serious problems with their voice, and are most of the problems caused by environmental factors?
Well, clinically, 10% of Americans have communication disorders, so some of those are going to be voice problems. What was the second part of the question?
Are they caused by environmental factors?
Environmental factors have an impact, but less so than daily use. So I guess it depends on how you define your environment.
Right.
I see, or before I retired, I used to see tons of MSU profs who taught in Wells 108. Okay, their environment every day, 2, 3, 4 hours a day, was a large, cavernous, resonant room. That was their environment. On the other hand, if you're in a rock and roll band and your environment is loud noise, well, that's going to have an impact on you. If we're talking about the natural environment, there's no way to measure those types of things. There's a lot of data on vocal load and voice use among professional voice users, and particularly public school teachers. They have set environments where they work, but if we're talking Mother Nature, that environment, that's almost hard to quantify.
Thank you. So that does it for the questions in the chat. We do have a few minutes left. Would anybody like to expound on something, ask a new question?
I have a question, kind of damaged larynx, when it's been removed, can a new one be transplanted, or a functioning larynx be transplanted?
Whoa, that's a savvy question. Yes, there are laryngeal transplants. The first one was done at the University of Michigan maybe a decade ago. They obviously require, anti-rejection meds over time. The tricky word you used there was functional. Yes, after a laryngeal transplant, folks do have a functional voice. There's not a lot of longitudinal data because the sheer number of laryngeal transplants is fairly low. The difficulty with laryngeal transplants is just sectioning and reconnecting the micro nervous system to make everything work well. But there's not a lot of data on the number of persons who've had a complete laryngeal transplant. To answer the question though directly, sure, it happens. They do have voice. They live a different life because of their rejection meds, but it works.
Mm-hmm.
I'm not aware of a laryngeal transplant in a child, but there have certainly been in adults.
Thank you. A new question came into the chat. Can you explain the relationship between the voice and Parkinson's disease?
Sure. Okay, Parkinson's is the lack of dopamine, right? There's a portion of the basal ganglia that creates that stuff. It's a neurotransmitter. It's generated in the substantia nigra. So what it does is the loss of dopamine to the entire body causes inconsistent action of the muscles of the entire body. So certainly there are things like a festinated walk, and the face is mask-like. There's not a lot of contraction in the facial muscles. And what that does is predisposes that patient to less control of the laryngeal mechanism, okay? So the vocal folds don't come together as tightly. Parkinson's voices are somewhat breathy and weak. And if people are losing air because the vocal folds leave that little gap, Parkinson's speech tends to be in short segments and spurts because they have to inhale more frequently, which leaves them a little lightheaded, by the way. Parkinson's patients, in terms of their communication, have something called dysarthria, D-Y-S-A-R-T-H-R-I-A. Parkinson's has a set type of dysarthria. It's a hypokinetic dysarthria, but it affects their speech mechanism. So face, tongue, soft palate, pharynx, vocal folds, all of those are slowed down and less efficient. So sure, you can understand exactly what a Parkinson's patient is saying, but it's probably softer, it's probably weaker, it's probably in spurts, but Parkinson's does affect the speech mechanism. It also slows down the swallow process. So we didn't talk about swallow dysfunction at all, but again, that's part of laryngeal functioning to protect the airway. It is possible in a Parkinson's patient that the swallow is degraded, and sometimes liquid or solid can get into the airway. They'll aspirate and maybe cough, or clearly if they aspirate it predisposes folks to pneumonia. So Parkinson's is a complex speech phenomenon.
Right. It is 11. So by all means, if you have a prior commitment, you may log off. But there is one additional question if you have just one more minute, Dr. Lapine.
Sure.
If exercise and movement is good for physical health as we age, what's the best thing you can share to help keep vocal health?
Spot on. Absolutely perfect question. Exercise and movement are good for our joints. Okay. The larynx has got a cricothyroid joint, a cricoarytenoid joint, a thyrohyoid joint. There are all these joints. Make them move. For the fun of it, if you remember, look up vocal function exercises. And those are literally ways that you can make the vocal folds dynamic. So singing exercises are great. You can take the word knowl, K-N-O-W-L, but when you say it, it's knowl, right? I'm not spelling it, I'm making the sound. So you can repeat no, 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 no. All right. You can go up the scale, up the scale. No, 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 no. You can go down. No, 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 no. Okay. You're moving those chords around. Look up vocal function exercises. There's quite a few that are really easy to do. I used to tell my patients, learn 3, do them in the car, especially if you're alone, so nobody thinks you're nuts, but they're not hard to do. And they do help retain the flexibility of the larynx.
Very good. Thank you so much. I'll turn it back over to Tom to close us out.
Yep. Thank you very much, Peter. Really appreciated it. And I think you taught us all a lot today about the voice. So again, thank you so much.
Well, you're quite welcome. It was my pleasure. Typical prof, I may have overproduced. You know, there's 131 slides and I probably did 22 or 23. Go ahead and look at them. My email is very easy, Lapine, L-A-P-I-N-E, at msu.edu. It's probably the second email address ever provided by MSU. That's how old it is. But if you read the slides and you have a question, feel free to give me a buzz.
Yep. Thank you very much, Peter.
We appreciate your time and your contribution. And there have been several comments in the chat just saying great program, wonderful information. So thank you so much. And it was nice meeting you. And on behalf of HASP, we just appreciate your contribution.
My pleasure. Thank you all.
Yep.
Okay.
See you soon, Peter.
All right,
bye, everyone. Have a great day.
Thanks.
Bye.